Thank you, Gag. Thank you very much for inviting me. And I would like to start with applause for the Planning Committee and the North American Thrombosis Forum for putting this together. So this is great for education. So my financial disclosure, that I will not speak about any off-label use. I do receive research support through Brigham and Women's Hospital, and I do have up-and-coming studies related specifically to thromboembolic event in hospitalized patient. I have another disclosure. My youngest brother did a postdoc fellowship here in the Detroit area, and I came a couple of times, and he called me earlier to remind me of what not to ask anybody around Detroit. But if you know M&M, please let me know. That's always something I'm on the hunt for. Our objective learnings are 4 and straightforward. And I would like to give you a glimpse on the national aspect of what VTE would be like in the coming years. I also would like you to know about the intersection between quality, implementation, and the scorecard about public reporting in the hospital. So we will discuss the critical care, critical role of hospitalist. And a hospitalist is the term that if you're in a hospital, or as my daughter described it as Dr. House, you are into that role where you do prescribe for the patients who has the highest risk, as you saw from Dr. Goldhaber, from Dr. Campia. Next, I would like to review the appropriate prescription, given what we know and the new flux of information that been shared with you earlier. I would like to address that role, the hospital medicine, in working and developing protocols and maximize the care and the quality of care, and emphasize the importance of VTE prevention in the era of that value-based care. This is how we will be getting paid as a hospital. This is how the public would know about our care and about the best care they are receiving after they leave the hospital. So just a quick question, not to pile on Dr. Campia. If you had to guess about the VTE measures that they were developed as a result of the national consensus standards, and this is the Joint Commission coming together with the advisory panel. So this is pretty much the government in how we regulate the health of the care delivered during hospitalization. Anybody would take 1 only, 2 only, 3 only, all of the above? So that was easy. So it's all of the above. So it's the prevention, is the ICU, as you heard, those at the highest risk, and also the hospital acquired. And that's the new measure of we are doing the best care going forward. So this is just to kind of wake you up after a big lunch. The hospital medicine is the descriptive science of those who stay in the hospital, care for patients. It grew exponentially, as you heard, and we are always treating those complex diseases management in the hospital. Across the nation, we have about 5,500 hospitals, and that is about 35 million hospitalizations a year in the U.S. If you take off the pediatrics and the delivery, we end up in about 17 million hospitalizations. So that is also would be in account about 5 to 6 million what is defined as medically ill hospitalization in the U.S. So the N is big. That universe is in every hospital, is in every acute care facility. When it comes to the barrier to what would be the best care delivery model, you could see these layers, and you could see that in your slide. And this is a slide that ARC been put around for many years, where we need to go through all of the above to deliver what is the standard of care and what is implied in similar domain like randomized clinical trials. In the next 2 slides, I will show you 2 major issues. The first one is where the breakdown happens. You heard again about the cutting edge clinical trials, New England publications. How can you get that to the bedside? And this is also from ARC, and as you can see, there are many failure level, and that's the emphasis of you as a hospital medicine, as a hospital medicine cardiologist, oncologist, and pharmacist to know how to prevent that failure. And when it comes to the hospital-acquired levels, it's almost the same. And to invent a medication, a drug that would go in the pipeline for 10 years to the publication and not apply it properly, that's another science. So in terms of the implementation, I shared with you that prophylaxis in hospitalized patient, it depends on the assessment, it depends on how we customize it, and how we get it to the patient at the bedside. And the goal of this slide is not to make you dizzy, but every day we go through the exercise of what would be the benefit versus risk in the patient. And if you could see that the risk profile or the phenotype of the population in the middle is pretty much, if you see patients in the hospital, is the biggest population that we see. At Brigham and Women's Hospital, we start sending patients home with what is home hospital is known if you have a single comorbidity. But most of the patients, they end up on the medical floors. They end up with these medical issues. How we've been doing so far. This is a study that Dr. Goldhaber led, and it's an international scorecards of the patients they should be on prophylaxis during stay. So first is the proportion of patients, and then the second figure is the patients that they were at risk and they received it. In the US is the point before last to your right, and you would see that it's not 100%. It's heartbreaking, but it's true. This is work that's been done within hospital medicine in University of California, San Diego. And every hospital will start with that baseline, and then they get the consensus, they put it in operation, they ramp up everybody to make sure we have a set, and that's the goal. If it doesn't get to the patient, that science never helped our patient. And as you can see, it is feasible to say that we can get up to the 99, maybe 95%, but this is the goal here. The goal is to get the drug and get it to the bedside. This is similar experience for those who are doing co-management with surgery or surgeons, where the surgeons also started from that baseline of 30 to 40% up to 60. With similar effort, they were able collectively to get it up to that 80, 90, and hopefully 100%. So in terms of best practice in hospital medicine, we do work on quality dashboards and incentives. And what I mean by incentives, it could be standardized RVU based on what we do in the hospital, and it could be something much simpler to show that our physicians, our clinicians, they are following the guidelines. So QI initiatives helped, and that's how we closed the gap between the guidelines and clinical practice. The education, roadshows, in-service, we also use that to buff up how we get to that 100%. Risk assessment tools and that decision guiding, I would lump it with the electronic alerts. My hospital implement Epic as the software universally across our network, which contains about 17 hospitals. And I can summarize in less than 5 hours our headache with Epic, but we ended up, and who has Epic, they know exactly what I'm talking about, but we ended up doing the best out of it and how we could put that in the context and deliver the care in terms of who needs it and how they get it, and we make sure they get it. Again, patient could refuse, Patient will not get it because they're off floor, and we try to chase them across the hospital to prevent that one VTE. The decision support my hospital is big on, and we generated many manuscripts, but the idea is it's not one size fits all. It is a risk and risk change when the patient goes to the ICU, comes out of the ICU. And we did an audit and feedback. Our role collectively is that prophylaxis stewardship. And someone told me just a second, this is a term that infectious disease use to know how to do antibiotics. And the answer is this is the same here, because you have more than one choice. You need to know when and how to make sure it will get to the patient. So you use that analog, that parallel of how we learn it from infectious disease. And please remember that there is a standard of care, and now we have evidence-based medicine that we need to comply with. And make sure that these medically ill at the highest risk, they are getting what they need to get. This is another slide from ARC. This is now the segue of what we will call the new era of medicine, the value-based, the precision medicine, where we need to assess the readiness. We need to make sure it's in a QI platform. We need to have that quality improvement priority across our hospital, across our health system. We need to monitor the process, analyze the return on investment, and you heard that, cost effectiveness, and make sure that that quality resource is also available. To continue with the same, I would say, efforts, we need to make sure we create the framework for that QI principles to continue. We need to emphasize that learning and make sure that the patients who are getting the VTE prophylaxis, they should get it, and make sure we have data collection. And that's how our practice would be informed of what would be the best. The Joint Commission is on it. It's one of the measures in their scorecard. The public will know about the exact rate outside research. And our role is to make sure collectively that this application and national consensus is there. So for my post-test, a quick one. This is CMS requirement on VTE performance reporting in 2013, and there is no subsequent Medicare or Medicaid services follow-up for the measure. Which of all of these items you think are in the pre-specified measures? I'm going to make it very easy. All of the above. So it's really that universe beyond the primary prevention, secondary prevention, assess the risk, making sure that we treat our patients of what would be a preventable. And preventable is very important word in everything we do, that it is preventable, and it's preventable 100%. So with this, I would like to thank you, and after this session, we'll be around for any questions. Thank you.
You showed us the beginning way to think about implementing prophylaxis. It begins in the hospital assessment of the patient. Only one member of the faculty has a double header today, and that's John Finicos. Right after his talk this morning, it was so good, I sent him an email. John, would you mind sending me your slide deck and let me borrow some of your slides for a lecture I'm giving next month? John, you really do it all. You run the Brigham Pharmacy. You do important research in cost effectiveness, and so in medication adherence and many other topics. But what you're about to talk about may be the most challenging item in your career so far to date. transition of care from hospital to discharge to home or to rehab facilities, do's and don'ts. I reintroduce John Finicos.